Okay, so today we're diving into a company called Talphera, and they are tackling a huge, really high-stakes problem that plays out every single day in what's probably the most intense part of any hospital, the ICU.
But to really get what's going on, you have to start right here with this question. When you hear top doctors, the folks literally on the front lines, using words this strong to talk about their best options, well, that tells you something is seriously wrong. There's a big, big problem here.
So what is this critical ICU problem at the heart of the story? Let's break it down.
All right, so we're talking about something called continuous renal replacement therapy, or CRRT for short. Now, you've probably heard of dialysis, right? Think of that as like a power washing for the blood, a few hours a week for stable patients. CRRT is totally different. It's a slow, gentle, 24/7 lifeline for the absolute sickest patients in the hospital. We're talking people in the ICU, often with multiple organs failing. It's life support. And this is where we hit the core problem. The moment a patient's blood leaves their body to go through this machine, it starts to do what blood naturally does. It tries to clot. And when it does, it clogs up the machine's filters, shutting down this life-saving therapy. For patients this fragile, stopping those clots isn't just important, it's everything.
And that constant threat of clotting forces doctors and nurses into what is, frankly, an impossible choice.
So doctors are basically stuck between a rock and a hard place. Option 1 is heparin. The problem? It's a total wild card. Sometimes it works, sometimes it doesn't. And worse, it can thin the blood everywhere in the body, which creates a huge risk of dangerous bleeding. Then you've got option 2, citrate. Now, citrate is good at stopping clots, but using it is an absolute nightmare. We're talking super complex rules, constant lab tests, and a crushing workload for the nurses.
And you don't have to take my word for it. This quote just says it all. This comes directly from Dr. McMahon, who actually runs a CRRT program and is one of the lead investigators on the study. He calls it an absolute pain in the ass. When an expert who lives and breathes this stuff says that, you know just how bad the situation really is. So what does this pain in the ass actually look like in the real world? Well, look at this number, 13 hours. These filters, they're supposed to last for 72 hours. That's 3 full days. But at one major hospital, the average filter only lasts for 13 hours. Why? Because the current options are so bad, they often just don't use anything. That's not just a small problem. That is a massive, massive failure. And that failure, it has a huge cost for everyone. For the patient, their life-saving treatment gets cut short, and they can lose a lot of blood every time a filter clogs. For the nurses, it's just an incredible amount of stress and work. And for the hospital, well, every one of those wasted filters costs them something like $2,300. It's a mess from every angle. Okay, so that's the problem. But this is where Talphera comes in. They're developing a third option, one that's designed to be both simple and safe. Their drug is called NIAID. And honestly, when you look at what it does, it's like a checklist of everything you'd want in an ideal solution. First, it only works inside the machine. It stays in the circuit. This is huge because it means the risk of the patient bleeding elsewhere is way, way lower. On top of that, it's got a simple, straightforward protocol. It's easy to get the dose right, you don't need all that crazy lab monitoring, and it's even easy to store. It just works. And the reaction from the people actually using it in the trial, it says it all. Dr. McMahon tells this story about how the nurses are just blown away. They're apparently peeking in and asking, wait, is that it? Is that all we have to do? They're literally telling him, please, finish the trial, make our lives easier. When you get that kind of reaction from the front lines, you know you've solved a real problem. So, okay, it sounds like a fantastic solution to a really tough problem. But how does this actually get approved and into hospitals? Let's take a look at their path to approval. Well, for starters, they just hit a really big milestone. They are now 50% enrolled in their main clinical trial. Now, that might sound like just a number, but in the world of biotech, hitting that halfway point is a huge deal. It shows they're making real, solid progress. Now, you might be thinking, okay, but what's taking so long? And this quote from another doctor on the study gives us some really important context. He explains that the study was designed to be extremely cautious. They're actually excluding a whole bunch of patients who are at high risk for bleeding, the exact patients who would probably benefit the most from this drug. So what that tells us is that the real-world use for this could be even bigger than what we're seeing in the trial. And the company has been really clear about the timeline. They're looking to finish up enrollment in the back half of 2026, get their application into the FDA right after that, and hopefully get a potential green light for approval sometime in 2027. And here's the kicker. They've got the money to make it happen. They've got over $20 million in cash. That's enough, they say, to get them all the way through that timeline we just talked about, right up to that potential approval date. That's huge.
All right, let's zoom out. Why does all of this matter? What's the big picture here? I think this chart really lays it all out perfectly. You've got the current options, right? No anticoagulation means the filters barely last. Heparin is super risky and doesn't work that great anyway. And citrate, yeah, it works, but it's a huge burden on the nurses. But then look at NIAID. It's aiming for that perfect sweet spot. Great filter life, low risk, and low complexity. It's the solution that could make everyone's life easier.
So when you think about it, for a problem this critical, in the most intense part of the hospital, is it possible that the simplest solution could be the one that unlocks the most value? For the patients, for the doctors and nurses, and for investors? It's a really powerful idea to think about.